Good afternoon. Today I'm going to be talking about how we are managing patient risks in the context of a nursing roster with a high ratio of less experienced nurses. I've been told not to use the word inexperienced because it's offensive, but in reality this is a situation that we're faced with. The Risk Matrix project came out of a review of 2 serious incidents that were near misses, and important information about patient behaviour was not clearly identified and communicated to other staff members. So we wanted to standardise a process where nurses are prompted to consider specific aspects of patient safety so that we could mitigate these risks. There's been a lot of papers on cognitive workload and the way that novices transition to experts, but we wanted to look not just at patient acuity, but also to look at other aspects of patient care where patients needed a high level of supervision. So the project has kind of evolved as we've gone along. It's given us a lot of data about our patients and also about the nursing workload in PICU, which we knew was increasing phenomenally, but we never had the time to stop and look at the numbers. It's making us rethink the way that we match our nurses with our patients, and what we're starting to ask now is how closely do I need to watch this patient and what specifically do I need to be watching for? And here, sorry, I'll do it twice. That'll be good in a minute. Right, so Westmead's a really busy unit, and I've used bunk beds in this slide because that's how it feels sometimes. And like many ICUs, we've increasingly struggled with our capacity and staffing issues in the last 5 years. We've recently opened a 6-bed close observation unit, which is located in another ward, but it's actually staffed by ICU as well. So that's been a new challenge in the last few months. Our nurses need to be both specialists and generalists at the same time, and we see a huge diversity of conditions. We care for children of different ages and sizes, ranging from premature babies needing cardiac surgery right up to adolescents with mental health issues. We're an ECMO centre, we use nitric oxide, HFO, and we dialyse babies down to 2.5 kilos in weight. We're the Paediatric Burn Centre for New South Wales, and we have transplanted a lot of livers this year as well. Many of our patients have comorbidities and they have genetic anomalies, and we frequently admit children with things that you've never seen before. Our nurses need to work with families, and our parents take it in shifts so that there's someone at the bedside all the time, 24 hours a day. So if you don't like being watched and you don't like people asking you questions about what you're doing, it's really not the right place for you. So I'd like everyone just to take a minute to think about what it feels like to be a new nurse in this environment. It could be pretty frightening, and I think that sometimes we forget how overwhelming it is. So we have a duty of care to our patients, and we talk about that all the time, but we also have a duty of care to our nurses to make it a safe unit where they don't become involved in incidents that are going to throw them off their game and possibly make them change careers. So ICU patients have a high number of activities every shift with multiple medications, invasive treatments and procedures, and information about these patients is complex and high volume. So our project uses a tool to prioritise how patient risks are identified and communicated. So we'll briefly look at the type of incidents that we were trying to prevent. Our educators have also been busy. They were concurrently, without us actually talking to each other, working on a nursing professional pathway which categorises where each of our 160 nurses are up to. So 2 months ago we employed around 30 nurses to staff our new unit, and there's going to be another 40 new nurses in order to staff that unit, so we're going to be up to 200 soon. So a fairly large proportion of that will be coming through with very little ICU experience and probably very little nursing experience in general. Like the risk matrix, the professional pathway is colour-coded, and we can use it to put an appropriately skilled nurse, if not with the patient, at least near that patient, so that the nurse has some support. I'm going to show you some data from the first 12 months of the project, and then we're going to have a look at how we're going to go electronic and what we want to do with the data to try and predict the type of nurses, the numbers and skill mix that we're going to need for a specific set of patients. So we looked at incidents where the patients themselves caused the displacement of tubes, lines and drains. So in the last 5 years, there are about 6 incidents every year where a chest drain, a central line, PD catheter, pacing wires were inadvertently removed by the patient themselves. And on top of this, we had about 2 to 6 unplanned extubations each year. Our rates of unplanned extubations are actually quite low, and each incident is always reviewed as part of our normal quality process. And there's a lot of discussion, I know, about what a healthy self-extubation rate is, because you've got to balance it with over-sedation, but I'm old-fashioned. I believe that we should plan when we're pulling these tubes out, and we should probably do it ourselves. The consequence of having to re-intubate a patient, you know, it's a risky procedure and it increases your length of stay and blah, 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 it goes on and on. So I personally think that if we plan it, it's better. And there's no harm in aiming for perfect. So we reviewed all of these incidents, and 9 to 12 of the line incidents doesn't sound too bad, but the consequences can be very serious. So a few children needed emergency re-intubation. Others had to have their important medications interrupted, like inotropes or something like that, and had to go to theatre, or have a line urgently reinserted. So we thought at least some of these incidents should be preventable. So when did they happen? They often occurred when the primary nurse was away from the bedside on their meal break or getting equipment, or had their back turned during a ward round or doing blood gas. So patient risks that should have been handed over to the nurse who was minding the patient were not. So another important finding was that these incidents often occurred in clusters, and it's touched on that. Clusters of events happen when you get an influx of new staff, and that's something that's pretty clear to see when we're looking at the incidence of these type of events. So the common reoccurring factors were unpredictable patient behaviour, being in a single room, and being cared for by a less experienced nursing staff. That's me on night shift. They didn't seem to be related to how sick the patient was. So you would think that really sick patients with lots of interventions going on would have lots of incidents, but it's not actually true. And it's quite simple, really, because in ICU, the sickest patients are usually allocated to the most senior nurses, and they have extensive clinical experience and they're able to recognise when things are going wrong, often before the event occurs. And when PICU is busy with a higher than normal number of sick patients, the senior nurses are busy with the needs of these patients, and they tend to cluster, and then you get clusters of inexperienced nurses in other parts of the unit, so they're not geographically supported as well as they should be. So less experienced nurses are able to look after high acuity patients, and in fact they need... Oh, that's a horrible slide. Sorry. Got my background there. If they're well supported, in fact, they need to do this in order to extend their range of skills and experiences. They are less experienced in managing uncooperative patient behaviour, and they also have less clinical experience. And without adequate support, they can miss small changes that can indicate clinical deterioration. And this is hard to avoid when you don't have an adequate skill mix on the roster. So this situation has already been described in Australian ICUs. In 2001, Ursula Beckman, who's now at John Hunter in Newcastle, and Anne Morrison, who's actually from Children's at Westmead, they published a review of critical incidents in Australian ICUs from what was then the new AIMS database. And they reported that errors are more likely to occur when nursing staff inexperience is combined with staff shortages, inadequate supervision, and high levels of unit activity. So that's all fairly logical, and that's the same conclusion that we've come to in a roundabout way. So it's important this time that we did something about it. So we decided to target nurses with less experience and to standardise the way that we define high-risk situations. So we wanted to teach nurses to think like an experienced nurse. So this is a grid that we came up with. We had a working party with some of our most experienced nurses and doctors, and we came up with 6 categories, and I've reversed it because normally you'd think the technology and the stability would be the main ones contributing to the events, but we found it was mainly behaviour and environment and other. So it was the skill mix, being in a single room, and the behaviour of the patient. So we're asking a senior nurse to go around and do a bedside round with every nurse and to talk about their particular patient in 6 ways. So what is the worst thing that's going to happen to this patient this shift? and they have to consider all of those 6 categories. This is a simplified grid. I'll show you the big one later. So we had a tool to identify which patients required the observation, so now we needed to decide what to do with this information when we're staffing the ICU. So ACCCN has defined that an intensive care patient needs to have an RN within them within 3 metres of the patient at all times. And that's an important definition for us to consider when we're staffing single rooms and patients that are geographically far apart. So basically, is it safe to leave my patient doubled while I go and have my meal break? Is it safe to leave my patient doubled while I go and do a blood gas? And it was also important that we developed a process. So at the beginning of each shift, the senior nurse does the risk assessment with each bedside nurse, and then they need to come together and communicate this to every nurse who might be in contact with that patient for the shift. So we have what we call a safety huddle, and it's also an opportunity for junior nurses to express when they're feeling out of their depth, and they can tell the rest of the staff what type of additional support they might need. So if they're not au fait with pacing or what other things they may need. So nobody wants to come back from their meal break and find this waiting for you. And knowing what to watch out for is even more important when you're only watching the patient for a short period of time. You can laugh, this is actually something very similar to this has happened to me. Well, I went for my milk. We want the nurse to say, we don't want them to say the kid in bed 6 is a VSD repair. We want them to say, he had a VSD repair, he's pacemaker dependent, and I think he's going for his wires. So that's what we want you to hand over. So translating workload into numbers has become a major focus of this project. We're used to looking at PICU activity in terms of occupied bed days and ventilation hours, and this is the graph that we've been showing at our management meetings for 10 years or so. And you can see there's not a whole lot of variability, and that's because we now run at over 85% capacity all the time. And to put this into context, the ACCCN estimates that 10 to 15% of your capacity is the time it takes for you to clean the bed and put someone else in it. So we are full. We also know that we've changed our patterns of invasive ventilation, so we are not using it as much, but that doesn't mean that the patients aren't as sick. In fact, it might be even more important that they keep their ventilation on, their masks on, their tracheostomy connected. So even though we're not invasively ventilating, that's not the only determinant of how sick our patients are. So I can compare 2 months there. In December we had 3 children on ECMO, and it was fairly catastrophic in terms of trying to staff with enough seniority for those patients. Our ventilation hours are slightly increased, but activity looks even lower than some other months. In January, half the hospital went on holidays and there was no cardiac surgery. So our ventilation hours are the same, but our occupancy is a little bit down, but not too much. But there were a lot of HDU patients sitting around just waiting for a ward bed, and it doesn't give us a lot of information on that. So we were looking for a better way to define what we have in our unit. So this is the actual risk matrix grid that we used. The first year of collecting data, the nurses just chose a category, put it on a piece of paper, and then we'd process it. The main thing to look at here is on the left-hand side, we've been able to add now the type of nurse that is needed for that patient. So a yellow patient needs a PICU 2 nurse. So if we go down here, this is pretty much a skill-based progression through ICU. And it's unashamedly skills-based because we believe that coming into PICU you need your skills, and then you do your communication and leadership training a little bit later on when you've got a bit more ability to think about those aspects of the care. So when we're using the 2 grids together, we can now say that if you're a high-risk patient or a yellow patient, then you need a yellow nurse to look after you. So all the data I'm about to show you, you can look at it to sort of reflect both of those things. So this data was collected over a 12-month period, and the nurses did a fabulous job of doing this on top of their normal workload. There's over 1,250 risk assessments were performed every month. So this grid includes 12,000 risk assessments that were done in the first year. So it's a massive amount of patient assessments. It gives us a clear picture of green nurses are nurses who are able to look after HDU patients. The orange 50%, standardly 50% through the whole 12 months. So they're people who need sort of around 2 years experience, so they're getting fairly confident. And the yellow ones at the bottom are sort of CNS or senior nurse, like leaders. Now this information doesn't actually, this is only nurses that were actually looking after the patients, so the yellow category actually should be a bit higher because there's at least 2 access and a TL every shift that's not included in these numbers. This is the same data again, looking at it in percentages. So we're looking at the actual patients that we look after at the moment, 25% of them need a CNS, and we are way below that in numbers. And in fact, like I just said, we probably need closer to 35% CNSs to properly and carefully look after the patients that we have. There's a lot of data coming out of the States at the moment with a clear relationship between poor skill mix ratios and patient outcomes. So this gives us a target of where we should be aiming to build and support our nursing staff to try and match these ratios. And this is bringing it back down to a micro level. So we're comparing here, the top one's a busy shift with lots of yellow, very sick patients and a high requirement for skilled staff. And the bottom one is when everyone was on holidays. So we quite often run on a skeleton staff, and I've had a couple of calls today about people wanting extra staff to work in. So if we have this sort of information 10 hours before we start calling for nurses, we know who we need. So we can supplement with an HDU nurse if we don't need the skill mix, or we know that we actually need CNSs to make it safe. So it helps you supplement the staff to match the patients. Sorry, I'm hurrying. So when my kids were little, I did about 5 years on night shift, and I always thought that people were sicker at night, so I thought I'd look at this. So this is information from our database, so not from the Risk Matrix project. So we're looking at comparing things that happen in the daytime during the night. So for many of the events like cardiac arrests, it's 50%, and that kind of makes sense. If we look at ECMO initiation, 70% of them happen after hours, so that's a little bit frightening. And if we talk about the type of admissions we have on night shift compared to day shift, they're unplanned. They're usually long cardiac cases that have been in surgery all day, and they're probably the sickest patients we see. And they're patients that are transferred in from nets, so that, again, they're generally sicker than, the routine kind of tonsils and fundoplications that we see that come in during the day. So there's a pretty good case there saying that our patients are sicker at night. So when we look at it with the risk matrix data, so this is our high risk, so this is the middle category, and 50% of our patients. So the black line is night shift. So for the whole year, almost, except in June, the nurses reported that patients were sicker at night than they were in the day. And this is the very high risk, so needing CNSs, again, more sicker at night than they were during the day. And HDU, less of them at night. So it pretty much confirms the suspicion. Oh, I'm missing a slide. Oh, lucky you. So we're looking at that data. So at night time, we don't have educational support. We don't have as much management support. Our nurse practitioners are not rostered on at night. So it actually builds a very good case for us to start supplementing some additional staff and getting the correct skill mix at night shift as during the day. Okay, so at the beginning of July, we moved to electronic data collection, and we've used the QAS database, which is from the CEC in New South Wales. So it's visible to anyone in New South Wales, but not able to be used by them until we kind of have it signed off. There's a little category at the beginning that talks about the shift, so how many planned admissions and discharges you have, and then we go through, there's 6 of these categories where you have to tick through, and some of them automatically give you a high-risk nurse, and other combinations of some of the things will escalate you to a high-risk category. And we are currently working on an algorithm so that once this assessment is done, it will tell you for the next shift we recommend that you need 16 nurses, 5 of them need to be CNSs, 5 of them need to be HTU, whatever. And certain thresholds will give you another access nurse. All right, so what have we achieved? So we had 2 incidents of prolonged ventilator disconnection, and that prompted us to look what was going wrong. And I'm happy to say that there have been no more of these incidents. And there's definitely been a change in the way that meal breaks are managed, and we get reports of staff using the risk matrix to support when they're concerned about leaving their patient with lower levels of supervision. We have been, since we've rolled out the new app, we've kind of had a blitz on making sure that the safety huddles are working, and as far as I can see, people are taking it very seriously and kind of understand that we will eventually, hopefully, be using it to support nurse education and the type of ratios we need in our unit. We haven't yet seen a change in the number of self-remove lines, tubes and drains, and we might not have seen a difference yet because the numbers are very small, so we're still investigating the best way to look at these and how to interpret these events. Unplanned extubation should probably be assessed differently to other incidents. So if the child didn't require re-intubation, I think we're starting to ask ourselves, have we missed an opportunity to extubate them earlier? And that's, again, a project that it's been involved with. And we're continuing to pay close attention to these incidents, and the pattern remains the same. So there's usually documented uncooperative patient behaviour, usually when sedation's being weaned, with an inexperienced staff member and during meal breaks, and it always seems to be a spike when we have a new influx of staff. And so in summary, the risk factors that we thought were causing incidents weren't, so we need to include patient behaviour and nursing inexperience and the physical location of the patient when we're looking at whether or not the patient is at risk. The inexperiences may benefit from a structured approach to identifying and communicating risks and learning from their senior colleagues in the way that they can identify things that can potentially go wrong. We are starting to use the risk matrix to predict staffing members and skill sets for each set of patients on a given shift. And it's validated some things, and I'll just say to anybody that if you think there's a problem in your unit, then the best way to get people to listen to you is to collect the data and have the numbers, because data speaks. And we're hopefully going to get some improvements out of this. So that's it.